I'm going to address progesterone and frozen cycle road for improvement ahead. No conflict of interest? Well, this is as we agreed, this is a case-based discussion. This is Mrs. MM, 29 years, married for 4 years, male factor infertility, antral follicle count 20, AMH 4.2. We proceeded with antagonist protocol. On trigger day, follicles 11 millimeter or more were 25. Agonist was given for triggering, and the decision of freeze all was taken. 22 oocytes retrieved, 15 embryos on day 2, left for extended culture, 8 full blasts were developed on day 5 and vitrified, 4 molars on day 5 were left for day 6, and 2 blastocysts were expanded by day 6 and vitrified. 2 months later, she came for frozen transfer. HRT protocol was first chosen. Well, why starting with HRT? The questions I would like to share and interact with you, as it's a live case. Why start with HRT? Before starting estradiol for HRT, should we give agonist? Estradiol, who want to start dose, duration, and monitoring for endometrium or for E2 level, if it helps. For progesterone, day of transfer from start of progesterone is a question. Route, dose, frequency, monitoring, and duration of use, whether for vaginal route, intramuscular, subcutaneous, and oral. Current role for endometrial compaction. Current role of ERA testing, and HRT current risks. Well, actually, HRT is one of the most commonly used protocols. For minimal, it's worldwide, it's 49% of HRT cycles are HRT, of preparation for frozen transfer are HRT, and more than 90% of donor are HRT, being minimal monitoring and easy scheduling to those performing IVF overall. Well, before starting E2, should we give agonist? First, if we give agonist in a standard way, it starts from day 21 of pre-treatment cycle and continue. The cycle will come. We start the estradiol and we continue with agonist till the end of E2 phase only, and we stop agonist with the start of progesterone. And if we are going to give long, ultra long, we can give the agonist for 2 or 3 months before the HRT cycle. So, should in this lady we give agonist? Before, there have been some evidence that giving the agonist before HRT was reported to decrease cancellation and increase pregnancy. However, recent systematic review and meta-analysis failed to show any benefit. So, but still, there is still a rule for agonist in HRT? Yes, it appears there's a certain rule. First, in cases of adenomyosis, as you see, 339 patients adenomyosis. This has been a retrospective study. A patient had received either long suppression with HRT versus HRT only, clinical pregnancy, implantation, ongoing pregnancy, higher in agonist plus HRT for adenomyosis. For endometriosis, this is 415 patients downregulated frozen transfer. It was associated with higher clinical pregnancy than endometriosis in fresh cycle. Interesting finding. What else? This recent study in fertility sterility last year, it is the retrospective data about 523 recurrent implantation failure. Endometriosis was excluded. These cases were 3 groups. 204 underwent, just I will minimize the photo, yeah. 1 minute, please, yeah. You hear me? Because my photo is absent now. It's okay? The presentation is okay?
Okay, Dr. Tamim. Continue.
Okay?
Continue.
Yeah. So 204 HRT only, 143 2 months agonist only, and 176 2 months agonist and aromatase inhibitor, 5 milligram oral letrozole daily for 60 days. Life birth rate were higher in agonist plus letrozole compared with agonist only or without pretreatment. Interesting finding. And this might be due to alteration in endometrium receptivity, as the investigator suggested, or treatment of undiagnosed endometriosis. However, this needs to be, as I already mentioned, these are retrospective data, and this has to be confirmed in prospective randomized control trial. Well, what about estradiol? The earlier, the better. Start estradiol from day 1 or 2 of the cycle. The earlier you start, the less likely you will have premature ovulation, which might disturb the whole thing. For the start, you start gradual or not. Some investigators start with 4 milligram and then increase it to 6 or 8 milligram, and the others, myself, I start with 6 milligram from day 1 or 2, and I complete till the total duration of luteal support, as I will mention later, and the others also start with 8 milligram and continue with the same dose thereafter. Some investigator with the start of progesterone or with pregnancy, they might decrease the dose to 4 milligram or whatever. However, both scenarios are working. It appears that they are working well. For the duration of estradiol, give it for, in general, for 10 to 14 days are fair enough to have a good endometrium in general. However, sometimes we have to prolong it, as I will show you. Not short duration, because some studies reporting the presence of good endometrium by 5 or 7 days and starting progesterone, there have been a concern of more miscarriages in these cycles. Target endometrium from 7 to 9 millimeter, and actually 9 millimeter gives the best cycles. The standard is to have 7 millimeter and more, but having 9 millimeter will relatively give you the highest pregnancy. Then continue E2 till 8 to 12 weeks. This is a large study for 1,000, almost 1,500 patients, freeze-all only, PGT, followed by endometrium preparation with E2 and progesterone, eubloid plus to cyst transfer. Variation in duration of E2 before starting progesterone does not impact the frozen eubloid. But please, ladies and gentlemen, if we read such a statement, we will say that, okay, with 7 or 8, it's okay. No. The average duration of E2 here was 10 to 34 days. So whenever endometrium is not reached by 10, you can increase. And in this study, they reached up to 34 days, and it was quite okay and comparable pregnancy rate. What about the optimal cutoff based on this large data? 917 young women, this study here, current March in 2020. The cutoff for endometrium thickness for the prediction of best outcome in this frozen cycle was 0.89, it's almost 9 milli. A study by Haas and Kasper in 2019 discussing the issue of compaction, as I will come to this later. However, they reported that the highest ongoing pregnancy was reported in endometrium thickness 9 millimeter and more. However, and it's very important, this large data, very large data, reporting about variable cutoff of progesterone. As you can see here, 8 millimeter or more high pregnancy, from 7 to 8 also high pregnancy, and there under 7 there have been lower pregnancy, but pregnancies with there till 4 millimeter. So, and their conclusion was that clinical pregnancy and life birth decrease for each millimeter of endometrium thickness below 7 millimeter for frozen transfer. Still, life birth rate is present with an endometrium thickness between 4 and 6 millimeter, lower but present. So this is very important. If the case or the lady has many vials for vitrification, counseling is very important. Whenever with prolonged estradiol and we were not reaching this 7 millimeter, we can counsel here that we can do go for transfer, lower pregnancy, but pregnancy is there, especially if she has multiple good quality vials. What about estradiol level? Some studies reported measuring estradiol on the last day before starting progesterone, and the cutoff have been suggested. However, these are large data published last year for 168 patients stratified into 4 groups based on E2 percentile on day of progesterone start. And as you can see, rock under the curve is nothing. Life birth rate comparable in 4 groups. Rock curve E2 in day of progesterone initiation, not predictive for implantation, clinical pregnancy, or our golden outcome, which is life birth rate. Well, what about progesterone? When to give target transfer on what day of progesterone? There have been many reports, but I got you the latest and the strongest. Okay, for after starting progesterone, day 3 embryo, get it back on day 4 of progesterone. Day 5 embryo, get it back on day 6 of progesterone. And very interestingly, recently now in press, this is a study by the group from Brussels Free University. Well, in the Brussels Free University, before 2017, they were practicing the transfer of day 5 plus on day 7 of progesterone. But after 2017, they changed their practice. So they proceeded to transfer day 5 plus on day 6 of progesterone, and they compared their data. These are retrospective data. When they compared the outcome between transferring plus to cyst in day 6 versus day 7 progesterone, the outcome was comparable. However, upon doing subgroup analysis, very interesting data appeared, which was for the group of patients who had shown delayed blastocyst expansion, and they were left for day 6. Upon transfer of this day 6 blast to day 6 progesterone or day 7 progesterone, pregnancy was comparable, but abortions were significantly higher upon transferring delayed blast into day 6 progesterone. So it might appear that for day 6 blast showing late expansion, upon warming and transferring this blast, it might be an idea to transfer this blast on day 7 progesterone according to this interesting finding. And this subgroup analysis has been done on 156 cases. So here, the delayed blast could be transferred in day 7 progesterone. In EFRE, we are, of course, this have been retrospective data. We are performing a multi-center randomized controlled trial, primary outcome, live birth rate, and the reported difference by Brussels group, we took it into consideration with power 80%, type 1 error 0.05, 167 women will be needed in each arm in each arm. So the total number will be 300 something to reach to a reliable conclusion. Of course, each group of each center does not have this large data about delayed expansion. So collecting all of us together, I think we can reach to reliable conclusions soon, inshallah. What about root dose frequency monitoring? Well, in Europe, as you can see here in these large data, 77% of centers use vaginal route, which is, of course, with less pain and less discomfort for patients. So trials to improve vaginal route of administration in frozen transfer is not stopping. Well, there is trend in rising studies. Now I'm talking about vaginal route in frozen HRT cycle, which with no corpus luteum. Okay, and this is different from fresh cycles. There is trend in last years to increase the dose and frequency of administration of the vaginal route. Maybe because with the vaginal route, the blood steady serum concentration is not that steady, as I will share with you in very short time. We know all the study by Devon, which actually changed the practice of people, when they compared in a prospective randomized controlled trial between vaginal progesterone versus intramuscular versus vaginal with every third day intramuscular progesterone, and the study had to be stopped prematurely because vaginal only route had high abortions, so they stopped it. But actually many of the criticism for this study is that they only used 2 tablets of endometrium per day, and many use 3 tablets of endometrium per day and are reporting favorable outcome. This is one issue. The second is quinone. For long it has been used once per day, and now rising studies reporting, yes, it is retrospective and it has to be tested in prospective randomized controlled trial, but still could be considered. They are using now 2 times of quinone, and this study by Alice Berg reported higher pregnancy and live births with double dose of quinone than single. Also for uterogenists and psychologists, they are used now 3 times per day, 200 milligrams 3 times per day, and even some reports reporting 400 milligrams 3 times per day. What about monitoring? Actually, there have been many studies reporting variable detrimental cutoffs. Let me share with you. This is Laporta, and I will actually discuss Laporta in more detail just in minutes. Laporta reported a detrimental cutoff 9.2 nanogram per ml in 6 progesterone day. Corbiotti cutoff 10.6 in 4th progesterone day. Cedrin 10 nanogram per ml in 5th progesterone day. Ellsberg 14 nanogram in 9th to 11th progesterone day. And this last study 20 nanogram in 16th progesterone day. So these are variable cutoffs. This study just in current year, they are retrospective data of 2010 cases, okay? Now they used the cutoff of 10 nanogram per ml, and pregnancy and live births were not different. The 10 nanogram per ml was not detrimental. However, when they used the 5 nanogram per ml, it was detrimental, and there was decline in pregnancy and live births. But actually, what about this study, which is variable, is that pregnancy here is low. Here it is 20 and 22 in clinical pregnancy, live birth 14. Here it's also low as you can see, 16, 22. When I reviewed the details of the study, actually they started 4 milligram estradiol from day 5 of the cycle. I don't know, but I think it needs also reconsideration. But interestingly, they come out with 5 nanogram per ml as detrimental. What about Laparta? Laparta, in her analysis for 211 cases, she have been using vaginal 400 milligram every 12 hours vaginal progesterone, and using the, according to progesterone quartile, in the first quartile with progesterone cutoff 9.2 nanogram per ml, pregnancy was lower in this quartile than the other 3 quartiles. And as you can see here, in this cutoff lower than 9.2 nanogram, pregnancy 32.7, and in those with higher values 52.8. And interestingly, 3 out of 10 patients had progesterone lower than 9.2. What else? Actually, she retrospectively, the first study, the previous one was a prospective cohort. When she came back to her old data, we are talking about 1,197 cycle donor and HRT, the cutoff here was 8 and the quartile, the cutoff was 8.8, and below 8.8, ongoing pregnancy was lower, clinical miscarriages were higher. This is another data. What else? What comes to our mind? Is this thing consistent? It means one cycle was frozen transfer using this protocol of vaginal. If this lady will go back again for the same protocol, would she have the same cutoff and the same criteria? And she answered very elegantly about this. In her data about 149 patients, yes, there have been consistency. 78 patients in another cycle was in agreement. 60 had progesterone higher than 9.2, 18 had progesterone lower than 9.2, 22 disagree. What about predictable? Yes, whenever you are measuring day 4 progesterone, low progesterone lower than 9.2 was found in 30% of women on day 4, 32.5 on day 5. So you can predict this issue 1 or 2 days earlier before transfer and see what you can do if something to be done. What about along the luteal phase? And this have been, she presented this data in last issue and last ASRM. This one was in last ASRM. Prospective cohort study, 150 patients, progesterone measured 3 times during luteal phase, 4th, 7th, and 11th day after transfer. Progesterone across luteal days associated with pregnancy, ongoing pregnancy showed higher exposure to progesterone. Results suggest that absorption to vaginal progesterone can vary among patients, and this can influence results. What about pharmacokinetics? Whenever we want to search for something, we go for pharmacodynamics and say, if we can find an answer. Well, we know blood level with vaginal administration of progesterone gives much lower levels than intramuscular, and actually demonstrated by the elegant presentation by Professor Ahmed and Professor Salah. But luckily enough, we know with the first uterine pulse effect and the enhanced absorption from vagina to the uterus, intrauterine concentration of progesterone are higher with the intravaginal application and low with the intramuscular, and we all satisfied that this will mean that we are delivering much good concentration, enough concentration for the uterus, and we were all satisfied with the vaginal. However, this very interesting study in Human Reproduction 2017 studied the effect of randomized serum progesterone concentration on secretory endometrium histological development and gene expression. This has been done on 47 patients and 10 control. They injected variable doses of progesterone. Here, the highest dose was 40 milligram progesterone intramuscular, then 10, 5, and 2.5. Secretory endometrium structure and function depends on progesterone concentration. Increasing frequency of delayed histologic development more than with the, but this happened with the very low dose and very low serum level of progesterone. Here, they have noticed delay, histologic delay, more than 3 days. This is one thing. And for the genetic expression, as you can see here, in control group and the group with high progesterone intramuscular 40 milligram, there have been consistency in gene expression, as you can see here. However, there have been deviation in gene expression in the group which took 10 milligram or 5 milligram
with low level of serum progesterone. Interesting data, and again have to be verified on the clinical level and not just as theoretical assumptions. Well, what was suggested by Laparta? She reported that adding other way of progesterone administration. She suggested to give, and actually she reported some of her patients given 25 milligrams subcutaneous, and she reported it's effective and rescued her cycles, either from, it could be given, either from beginning of vaginal use or rescue dose on day of transfer if it was lower than 9.2 nanogram per ml. And they reported favorable outcome even when she gave the rescue dose on day of transfer, and reported rather than to have 32 pregnancies, she reported the occurrence of 50-something pregnancy. Also, she reported, or she suggested to probably increase the dose and frequency of progesterone or change the type of progesterone. Well, what about intramuscular? It's painful, of course. However, it maintains a good blood level. And of course, with the study I already mentioned, it's already of high prevalence of high use in US, and some changes their practice to shift to the intramuscular. I think what we need is to go again to the vaginal and see if this is the best out of it, or we can refine it, but on a prospective randomized controlled trial to come out in a research institute to come out with reliable conclusion. For monitoring of intramuscular, these are two completely contradictory studies. This study 168 patients HRT cycle using 100 milligram intramuscular progesterone. Optimal cutoff for predicting ongoing pregnancy was progesterone level 20.6 nanogram per ml. However, in the contrary, on this study, 213 patients, HRT and donors, but they used variable doses of progesterone, and Dr. Salah elegantly demonstrated that 5 milligram is different from 1,000 milligram. However, they used 50 or 75 milligram IM. But the thing is, they did the transfer fixed day 19, and of course, in medicine, nothing is fixed. E2 varies according to the sickness, etc. And they reported that progesterone level higher than 20 nanogram per ml on day of transfer were associated with decreased ongoing pregnancy. Ladies and gentlemen, actually with intramuscular progesterone, blood serum is sustained around 20 and 30 and 40. So I don't know too much about the explanation of this study. What about subcutaneous? Dr. Salah, well, first 25 milligram were reported in this study to be comparable to vaginal progesterone, but actually what Dr. Salah actually elegantly demonstrated here, it's again with 25, you see here the low level, with 50 we have higher level, with 100 we have more and more higher level, and not only that, but you maintain the high level for 24 hours with single application with high dose injection. So again, I think we need to furtherly study this issue about subcutaneous progesterone. For oral, this study, 180 patients, 2 tablets twice per day, comparable to vaginal progesterone. But, well, I actually took this slide from my mentor, from our idol in the ART field in the whole world, Professor Yacoub Khalaf, for what he just stated yesterday about the use of oral progesterone for luteal support. It's a serious issue. Organogenesis takes place at this time, and therefore there is the possibility of harm, not only for congenital anomalies, but also long-term and even intergenerational effects. Anyone investigating the use of steroid hormone in first trimester should remember DS, legislation of harm, and there is evidence that there is potential harm from progesterone, particularly congenital heart disease. So I leave it for time. For duration, it's quite variable. Dr. Salah mentioned all things about the fresh. For the frozen, we all wait for the so-called uteoplacental shift. And in general, the most trend to continue HRT from 8 to 12 weeks. However, this has been mentioned by McKeans in his elegant review that caution when using HRT is warranted since rate of early pregnancy loss is alarmingly high in some reports. And here again, I remind you with the, of course, it's a small number of data by Laparta about frequently measuring progesterone in luteal phase and keeping high level of progesterone and end up with a higher clinic ongoing pregnancy? I don't know, but I think we have to ascertain these data. What about the endometrial compaction? Well, it's the endometrium compaction. It means decrease the endometrium thickness between the last day of and when the maximum measurement of endometrium thickness are taken just before the start of progesterone. And then this is one measurement. And then on the day of transfer, if we see this decrease in endometrium thickness, this is what Professor Kasper and his colleagues named it endometrium compaction. It's actually what we have in literature is quite variable. This two studies by Prof Kasper and colleagues, one published last year in Fertility Sterility, 271 patients, and the other one 234 patients. In the first study, he reported that compaction means decreased endometrium thickness 10% between the day of transfer and the day before starting progesterone. Compaction 10% or more was associated with higher ongoing pregnancy, and in the second study, compaction 15% or more was associated with a higher ongoing pregnancy, and compaction was reported in their study between 30 to 40%. However, this large data over 3,091 patients reported totally contradictory result. In compaction occurred in 25% of cases, and it was accompanied by lower ongoing pregnancy in comparison to non-compaction group. This study by our group, we submitted this data to the ASRM current year, inshallah. The objective was to assess whether endometrium compaction on day of frozen transfer has a role in optimizing pregnancy outcome on frozen soot cycle. Further, to investigate possible interrelationship between occurrence of compaction and progesterone level on day of transfer. According to sample size calculation, 220 patients undergoing a good quality frozen blastocyst transfer, 3 bb and more, are to be included, or patients received E2 6 mg daily. We started on day 1 or 2 and 100 mg IM. This is our protocol. Endometrium thickness was measured by transvaginal sonar at end of estrogen phase and on day of E2. Progesterone was measured on day of good blastocyst transfer. And to be noted, and it's very important, that there is marked inter-observer variation in measurement of endometrium. The three most experts had to sit together to take the exact measurement on day before progesterone and on day of transfer, because whenever there is 1 millimeter difference from 10 millimeter and 9, you are talking about 10% compaction. So it's totally subjective and has to be taken very carefully. And even we had to make a backup with 3D folium contrast imaging to increase the accuracy of our measurement. So it's not that easy, and it could be actually not that accurate. So it should be taken and interpreted very carefully. Preliminary data of 120 patients were submitted. Ongoing pregnancy, it was higher in compaction, but it did not reach statistical significance. So we can't say any statement yet. Furthermore, endometrium compaction group had a comparable progesterone level on day of transfer to those without compaction. And interestingly, ongoing pregnancy was comparable between the 4 progesterone quartile. What I can assure you that whenever you are giving intramuscular progesterone, you have a sustained blood level of progesterone. We used to measure progesterone on a fixed day. So we used it to measure progesterone 2 hours before the next injection. So it means 22 hours after the last injection. And in all scenarios, progesterone level was around 20, 30, 40 and more. The validity of these findings will be determined through the observation of the remaining cases. Well, EFRE is performing a multi-center cohort non-intervention observational study to evaluate whether compaction would have impact on rate of birth, pre-eclampsia IUGR. 1,250 cycles are needed, resulting in 300 live births. This can detect difference in live births at 98 power, 1 alpha error, pre-eclampsia at 87 power, 5% alpha error, currently formulated with Prof Kasper. Current law of ERA, well, we know ERA, it has come out to study the 238 genes and giving promising result, But I can assure you that now ERA is a dying art with these two studies, the one by Hashimoto et al. In 2017 using ERA. They determined whether endometrium receptive or non-receptive before transfer. Implantation in the receptive group was not significantly different from non-receptive group. And this is a group by Prof Kasper and his colleagues. 503 patients control frozen transfer without ERA testing. 41 following ERA adjustment in frozen transfer according to ERA resulted in pregnancy comparable to control. Well, there is rising concern about the obstetric problem with HRT. This have been retrospective audits in May 2020. More than almost 7,000 women were included. As you can see here, risk of low birth weight, preterm birth, hypertensive disorder with pregnancy is higher with HRT than natural cycle. Ovulation induction group significantly higher preterm birth, but the issue of low birth weight or hypertensive disorder is lower. So alternatives, as we are doing our best to fine-tuning HRT, I think we should also fine-tune natural and modified natural, because the role of frozen transfer is more and more increasing. Allah, thank you. EFRE is always committed to science, education, practice, and ethics. Thank you.